As part of the CCSVI, how come the retevo veins aren't angioplasty?
Well, it's a good question. What tends to happen with the vertebral veins is they increase in size in response to the abnormal jugular veins. Remember, the jugular veins are taking over about 85% of the flow. And what ends up happening in patients, and if you saw a grade 4 venogram, a really impressive grade 4 venogram, what you would see is that very little flow goes through the jugular veins, but a huge amount of flow goes through the vertebral veins. And so you already have a situation where the vertebral veins are huge, massively dilated. The real question would be, if all the flow is going through the vertebral veins because of this process, should we be trying to divert some of the flow from the vertebral veins back to the jugular veins by making the vertebral veins more narrow? And unfortunately, I don't think anyone's gone down that pathway yet of saying we're going to try to occlude the veins that are taken over for bad jugular veins. What we do notice is that in some patients, when they come back for a repeat venogram, jugular veins that were small, once they've had the area fixed down below, they were small up above, they had other areas in there, they'll increase in size, and the vertebral veins that were big now will decrease back to what's more of a normal appearance of the vertebral veins.
Thank you. Other question is, early in the presentation you used the acronym PTA.
PTA,
What does that stand for?
percutaneous transluminal angioplasty. Percutaneous means we go through the skin. I tried so hard not to use acronyms, I really apologize for that. Percutaneous goes through the skin. That means we're going through the skin. Transluminal means we're going through the lumen. We go into the lumen is the inside of the blood vessel. And then we go through the lumen to do the angioplasty. The angioplasty is the part where we dilate the balloon and increase the size of the blood vessel, PTA.
Dr. Sars, I was at your Vascular Institute last May, but I was wearing a blue cap when you last saw me.
I was too. We probably look very similar.
Correct. I want to ask you, doctor, when a person restenoses, and a lot of patients do after 6 months, because the veins are so fragile, how often do you think a person can have a procedure? I know there are many patients who have had a second procedure, and I would think that the possibility of having 4 or 5 would not be possible, that it wouldn't be possible to do
I
it
think
that
it's another, all of these are good questions, and I could easily just say, okay, for every question you ask, the answer is I don't know, but I'm trying to give you educated descriptions based on what we know from other parts of the venous anatomy. Your point's a good one. Veins narrow, and I made a point of stressing that during the procedure. After you do an intervention on a vein, it is going to narrow back down, and probably about 50% of them will get significantly narrowed. The goal is to try to open them up to a point where when they do re-narrow, they don't get to the point where they, again, cause symptoms. Assuming they do get to the point where they're causing symptoms again and they need to be retreated, we don't know the maximum number of times they can be treated. We do know that from other parts of the body, patients who have hemodialysis and need to have their blood, basically need an oil change every 3 days or so, to have their blood changed out, they have what's called an AV fistula created. And what that means is that they have a connection made between an artery in their body and a vein in their body so that the blood flows directly across a circuit in a very high flow fashion close to the surface. And that allows the dialysis unit to access that circuit and take the blood out. That's a vein. That's a vein that is used to create that structure. Those veins narrow. And over many, many years, what we found is that the best way to treat those narrowings is to go in and do a balloon angioplasty. And what ends up happening is they narrow over and over and over and over again to the point where I have patients who I've done balloon angioplasties on their fistulas for 15 years, every 3 to 6 months. So the fact is we have models that are similar to this. Now, not exactly the same. The fact is that's a really high flow system, and probably it's going to get more stenosis than the veins that we're talking about, but we do know that we can do repeat treatments over and over and over again. That's why we don't want to use stents. Because if we do something like an angioplasty, generally speaking, we can cross that bridge back and forth a couple times. Once a stent is in place, that bridge is crossed, and you may or may not be able to do much about it. Okay.
Sorry, does the narrowing go back to its original when you started, or does it go narrower?
No, actually, the goal is for it to go less narrow. We try to over-dilate, or at least dilate to the point where when the vein does re-narrow, or whatever, narrowing is probably the wrong, we're talking about narrowing when really what we should be talking about abnormality. A lot of times it's not really a narrowing, it's a valve that's not doing what it's supposed to be doing. It's an area where one side of the valve cusp is stuck up against the wall, or the other side is stuck to this side so they don't open appropriately. So the goal is to open up those valves. But what happens is every time you do any intervention in a vein, I mean, the concept of treat the valves but don't treat the veins, it sounds like a good concept, but you have to understand the valves are an integral part of the vein. You can't treat the valves without treating the segment of the vein where the valves are located, okay? So the idea is you want to disrupt the valves, dilate whatever area is for whatever reason acting like a narrowing, acting like an obstruction, to a point where when and if it re-narrows, which we think is going to happen, it won't re-narrow to the degree that it was, or to the point where the valves were causing the obstruction. So your goal is to try and have a repair that's going to give you a durable enough response so that you're not going back in there every 3 to 6 months. And basically you're intuitively hitting on the problem with this approach. This approach is not perfect. We know that veins don't like to be dilated. That's why there are people in other parts of the world who are talking about things like biodegradable stents, stents that are placed into the vein and then degrade over time. I'll tell you, it's something that interventionalists have been talking about since at least 1992. So, don't hold your breath. And then other people are talking about using drug-eluting balloons and drug-eluting stents to try to decrease what's called intimal hyperplasia. That's the fancy word for scar formation in the vein where you do the dilatation. It works in small blood vessels, arteries, in the coronary circulation. It has not worked in other blood vessels. So we don't have any reason right now to think that we can apply it to veins, but everyone's working on solutions to this problem. How do you dilate it and get it to stay where it was when you did the dilatation?
On the same topic, are the valves always, you always treat the valves as well, disturb them as well?
Yeah, I think, and someone asked me this question earlier in the night. There's this sort of misconception that you can somehow treat the valve without treating the vein that the valve's adjacent to. I could easily fix that problem by showing you an anatomic specimen of what a valve looks like inside a vein. But the fact of the matter is, you can't treat the valve without treating the level where the vein has its valve located. You can dilate the valve and try to dilate it just to the point where the balloon does not reach the outer part of it. But usually what you're doing is, the vein is a very floppy structure. It's very compliant. It can dilate significantly to the size that you have. You dilate a balloon into the valve that's at that level. The valve is what's causing the problem, but the balloon dilates around the valve. There's a narrowing right where the valve's abnormal, but the balloon dilates to its nominal size all around the valve. And so that structure, the balloon itself, is touching the vein wall outside of that little hourglass shape where the valve is located. And that's the problem. If you're touching, anytime you do anything to the wall of a vein, it's a very delicate system. It's a brilliant system. I mean, the lining of the veins, these cells know how to stop blood clots from forming. It's an amazing, amazing thing. But when you damage them, when you dilate a balloon into it, they don't do what they're supposed to do anymore. And frankly, what they do is the opposite. They try to make blood clots form. And they do it for a reason. Veins think, oh, I'm damaged. I have to clot so that you don't bleed to death. And that's the whole point of the system. So we're trying to defeat the natural system to do what we're doing.
You mentioned that a patient would have to continue using their medication. What would happen to patients that are taking chemo boosters and Copaxone? Would they have to continue those treatments?
Maybe I misspoke. I don't tell patients they have to continue taking their treatments, but what I recommend is that they consider continuing, because I don't think we have enough science yet to say that that part of the problem isn't being treated effectively by those drugs. In other words, if there's a part of your problem that is, for lack of a better way to put it, because the horse is already out of the barn, in other words, we've already gone down that road, plaque has formed and your body's reacting in an autoimmune way, or you have sclerosis that's not now, it's not an ongoing process, but you still have inflammation. By treating the vein problem, we're going to decrease new plaques from forming. We're going to decrease new blood vessel problems from occurring, but you already have areas that are beyond that point. And that may be the point that you're going to benefit from continuing on whatever drug therapy you're already on. And we don't know, is the short answer. We don't know the answer to that. So it's very difficult for us to recommend patients to come off of a drug, especially if they've had benefit from it. Now, if a patient has had no benefit, their relapse rate increased when they went on Copaxone, for instance, or they're taking some other drug and they're having terrible side effects and they haven't noticed any benefit, it's a lot easier for us to say, your call. I mean, we're going to do the intervention. If you feel better after the intervention and you're not getting any benefit from your drug, I can't really see a reason to continue with it.
So if, say, they had to because it didn't work, would our doctors still here take those patients, or would they turn against that patient because they don't believe in what you're doing.
You're asking the wrong person. You know, I think that any doctor who would turn against you because you tried another treatment for your disease that wasn't responding to their therapy, probably, I should start that sentence again. If a person did this, then they really shouldn't consider themselves physicians, frankly, because we're not asking them to change their therapy. We're just trying to help with something additional.
I'd like to add something to that. We've kept track of all of the primary doctors who have treated patients that come to our clinic, and over 200 of your physicians, your general practitioners here in Canada, have supported their patients when they returned and have worked with us. We send the reports to them, we keep them informed, and I have 200 that I can document today. So a lot of them.
Yeah.
I think I can answer these questions about drugs a little better. I was told after my first procedure that I should continue on the drugs. Being male and obstinate, I couldn't listen. I stopped taking those drugs. So you see, to me, it made no sense. I'm not a doctor, so I can answer it the way I choose. I didn't take them because it made no sense, because blood flows in the body that got fixed. So what the hell do I need drugs for? That's the way
It's
I
a
thought
patient's
about
call.
it. So I stopped taking them within a week of my first procedure. The effect? No side effects. Nothing. Your veins closed? Yeah. Go ahead. You have that now? Did your veins close in? That's the procedure. There you go. I had the procedure, my blood flow was restored, and I didn't need drugs. That's what happened to me. And it's happened to probably 1,000 people I've talked to in the last year. So whatever your decision is, it's a personal choice. My choice was, the hell with that. I'm not gonna take drugs that don't work in the first place, so hell with it. I'm not doing it. And I can give you 1,000 more examples of that if you want. So make your own choice. Make sure it's a choice that, I mean, if you've had a procedure and your blood flow is restored, tell me, what do you need? Exactly.
One question. Let's say that you want to go for the procedure. Is it best to get your, general doctor or some specialized doctor to give you some support before you go for any procedure, so that at the end of the procedure, that final outcome or the report will go back to your family doctor so that they can monitor you, just to kind of keep track? Or is that
No, yes,
handled
yes,
independently?
no,
Or
no.
should we get, let's say, our family doctor's approval or some support before we do any procedure?
The answer to your question is yes, you should if you can, because I think that, very often our patients will require some form of therapy after the procedure, which is much more easily managed if your primary care physician is willing or interested in being involved. Typically, that's an anticoagulation issue.